My name is Elisa Edelman. I'm a Foreign Service Health Officer with the Office of Health Systems, and I'm very happy to introduce you to the next session on health systems response. Just as opening, and as we've heard in the previous session and in Kelly's remarks, and I'm sure will be referenced throughout the day, we all know that the first line of defense against public health threats and other shocks is an effective and well-functioning health system. At the core, I think we can all agree that we need a basic level of staff and equipment, of data, of medicines, of money, of quality services, just in order to respond. But I think we also know that among other things that we can't just have essential functions in place. It doesn't guarantee that a system can cope with the changes and shifts that a crisis brings. If you have funding, but you can't move it from one budget line item to the other, or if you're unable to reprioritize staff, or triage your services, or find ways to formally work with new kinds of partners, your response will be limited. In order to build resiliency, there's a need to focus on the dynamic dimension, the need for building flexibility into operations and management, the ability to quickly and swiftly reprioritize objectives and resources. And beyond the immediate response, there's a need to learn and improve from system weaknesses, to adapt and to better prepare the system for the next shock. And in the long term, there's a need to look at the systems around rules, processes, and learning approaches to be able to transform the system essentially to then be able to respond better and better in the long term. So with that quick opening, I'm very honored to introduce our esteemed panel that's going to help us with this discussion today. So first, Dana Hovig is a senior advisor at the Bill and Melinda Gates Foundation. He just has rotated off of a role as director of integrated delivery, and he's managed successful healthcare programs in 5 continents and has had other roles with Marie Stopes International and Population Services International. Welcome, Dana. Richard Green is a senior infectious diseases strategy advisor with USAID. He served in many different leadership roles with USAID, including Senior Deputy Assistant Administrator for USAID's Bureau of Food, USAID's Bangladesh Mission Director, Director of USAID's Office of Health, Infectious Diseases and Nutrition, and other roles. And Karima Saleh is a senior health economist at the World Bank. She has over 20 years of global health experience in policy and project management, and she's worked extensively overseas, including in more than 25 countries. So welcome to our panelists. The format for this session will largely follow what we just had for the previous session. We'll have discussion amongst the panels, and there'll also be time for questions and answers from the audience. So with that, we'll begin. So the first question is for all of our panelists, and we're going to start with a very broad context-setting question. If you could please describe how your organization is currently thinking about and investing in health systems resiliency programming, that would be great. Karima, would you like to begin?
Yes, thank you so much. First of all, thank you very much for this invitation, this opportunity to come and speak with the audience here. I'm from the World Bank, and as most of you may know, that World Bank has an intersectoral approach. It has many disciplines working, macroeconomic, sector-oriented health, education, social protection, agriculture, etc. So we have a very dynamic system, and we look at disasters in many different aspects, including health, agriculture, climate change, etc. So in health system strengthening area, I wanted to sort of talk about a little bit about the resilient program that we look at. So some of the issues that we really need to address are systemic issues that need to be actually happening at a normal level, whether there is catastrophic conditions or not. 3 areas that I would like to emphasize here is governance aspect, financing aspect, and delivery aspects. So in the governance aspects, to see we work towards helping governments towards developing policies, strategies, plans. For example, many countries don't have a program or policy on private sector development. They don't have some understanding of HR planning. They perhaps have a very outdated planning system. Maybe they have a very outdated education system. Building accountability mechanisms to create some sort of incentives, and monitoring and tracking systems. These days, we're also starting to talk to governments about preparing emergency preparedness plans so that when there's a catastrophic situation, they at least have a response system ready. In the financing aspects, advocating for sustainable domestic financing, including public sector financing, advocating to help perhaps develop some innovative financing technology tools. For example, in many countries we are talking about tobacco taxes as additional financing options. Creating space for private financing and credits. As you may also know that we have the International Finance Corporations that we also have a sister agency. Ways to protect people, financial protection mechanism, user fee, exemptions, cross-subsidization, and in addition, advocating for emergency epidemic contingency funds. Finally, I want to just talk about service delivery. Many countries don't have surveillance systems in place. This is critical. Thinking about how do we partner with non-government agencies for service delivery aspects. Many countries don't even have a mental health program in place. Very important to look at equity dimensions. How do we address the poor, the vulnerable, the remote areas, the disaster-prone and conflict-driven areas? And we have now developed some international global funds financing facilities, which I'll talk to in the next questions. Thank you very much.
Dana, or go ahead.
Thanks very much. USAID does quite a bit in terms of resilience programming, and I'm not going to talk about the health system strengthening portfolio, which you've already heard quite a bit about, or the Global Resilience Initiative, which I understand you're going to hear about as well. I will talk about something called the Global Health Security Agenda, which is an international initiative with over 60 countries and organizations trying to address infectious disease threats that are especially related to epidemic-prone diseases. For years, we supported maternal and child health system strengthening programs. We also supported infectious disease programs addressing the big endemic infectious disease such as HIV/AIDS, TB, and malaria, but we never really addressed the epidemic-prone diseases. Now, with these types of threats increasing, the Global Health Security Agenda, both internationally and what the U.S. government supports, fills an important gap. The Global Health Security Agenda is both a resilience and a health system strengthening initiative. The whole point is to detect infectious disease threats early, to respond rapidly and effectively to these threats, and to prevent those outbreaks which are avoidable. Some of the key areas involve surveillance systems, both on the human, the public health, and the animal side, national laboratory systems, both on the human and the public health side, zoonotic diseases, which represent about 70% of new epidemic-prone diseases, as well as other things such as emergency operations centers, etc. AMR is an emerging threat, and that is included within the portfolio of Global Health Security Agenda. And again, that's not only on the public health side, but also increasingly on the animal side, as well as risk communication, as we've seen by some of the challenges of the Ebola outbreak in Eastern Congo. Having strong community engagement and risk communication capabilities are critical to address any infectious disease threats. Some of the key aspects of how the U.S. government and USAID address global health security involves strengthening communities that are particularly at risk, having a multi-sectoral program that not only includes public health, animal health, but also the defense, security sectors, etc., but also making sure that these sectors are well linked together so that information on the animal health side is shared with the human side as well. So that's kind of a general introduction to the Global Health Security Agenda program, which we feel is very much a resilience initiative.
Thank you.
Great, thanks. So I'm Dana Hovig at the Gates Foundation, and we're smaller than our colleagues at the bank and USAID. What I think we make up for that in being quite a complex organization, arguably more complex than our colleagues here. And I'm not going to try to unravel that complexity. We have 30 teams at the foundation, each with their own strategy, each with their own budget. I'm going to talk a little bit about the team that I ran for 5.5 years, and then a few of the other teams that are focused on more specific sort of subsystems around health systems and health systems resilience. So we work at 3 levels in terms of health systems, health strengthening and health systems resilience. At the country level, a focus on Nigeria, Ethiopia, and India, particularly UP and Bihar. We make and are a major investor in the global financing facility run and led by the World Bank, which we see as a key health systems lever to strengthen health systems around the world. And then we have a thematic focus. And our thematic focus in health system strengthening is really around 3 or 4 areas. Around health financing, which I can talk about later. Around health systems management and governance to help health systems become more adaptive and nimble. And then around health systems design, which we think is a really important investment area for us moving forward, particularly for fragile countries as they make decisions which will help or haunt them in terms of their health system 20 or 30 years from now due to path dependency. We also make some major investments in routine systems and country data systems in places like Tanzania and Malawi and Ethiopia. We feel like that's a hugely important cross-cutting area for health system strength and resilience. So that's a sort of a big picture of our health system strengthening portfolio and where we're investing as a team and a foundation. Other teams also are investing, for example, in state-of-the-art surveillance systems, national recurrent surveillance systems in Sierra Leone and Mozambique, which can help to transition to vital registration systems in those countries and hopefully be archetypes or exemplars for other sorts of countries. As Richard said, through our global polio eradication initiative investments, we invest in emergency operations centers in Pakistan, Nigeria, and Afghanistan, which we know, for example, have been repurposed for Ebola and measles outbreaks in Nigeria. And our malaria team is actually planning on investing in emergency operations centers in 3 other countries, which can also be repurposed and used for other things beyond malaria surveillance. And the last thing is we're leaning into heavily some post-polio planning. As Sohail said an hour ago, there's 2,000 health workers out there, polio workers, who have been repurposed for other sorts of outbreaks, and that is such an asset for the global health community, and we are quite worried as a foundation that may dissipate and disappear as polio becomes eradicated. So thank you.
Thanks very much. That was really helpful to hear the perspectives and sort of better understand where you're coming from on this topic. Now, to get more specifically into the subject matter for the session, I'm going to ask another couple of questions, and I'll ask the same questions to all of the panelists, so you can feel free to jump in on this one. What do you think a health system needs to effectively respond and adapt to emerging crises? And then again, Ebola has come up this morning. I imagine it will continue to come up throughout the day. What are the lessons we have learned from this era of Ebola that we're in with regard to how health systems should adapt and respond? Anyone can go first.
So thanks again. So I'll just broadly respond to both the questions on this round. When an emergency situation hits the country, the immediate response that you see is loss in public financing, loss in financial protection of people, loss in reduction in service use, both because of supply constraints and demand challenges, rise in possible endemic and epidemic situation, new diseases coming up, rise in mortality and morbidity, loss in HRH, and breakdown in system. And particularly primary healthcare is very much affected, particularly in the areas that the disaster affects. So these are critical areas that we have to think about in advance. How do we have a sustainable system available so that they can respond? They cannot buy drugs, they cannot buy equipment if financing is not available. They cannot protect people if there's no social protection mechanism available. There's immediate injury is happening, immediate accidents are happening, or require from quarantine systems, or a requirement for hospital care, that is where the challenge is, because the system is not responsive. Keeping vigilance is very important, so the monitoring systems, surveillance systems are very important, which often is lacking. Just to respond on the Ebola situation, some of the lessons learned is that surveillance is critical to be able to detect early on the challenges. Communication systems are critical. I was in Philippines when we had SARS and avian influenza, and the mobile technology was critical, and actually working with the mobile programs with the private sector in identifying where there was an outbreak. And that was immediately an area where the response system could come through. HRH access beyond the public sector, how do we work with NGOs, how do we work with CSOs in communication, as well as national or international labs, laboratories where you can send specimens for testing, etc. If you have the network already set up, that's very easy to move towards, otherwise there's a challenge on that. USAID, CDC was critical in many areas where we had Ebola programs, and that immediate response system that is available, immediate response system that could come, and international financing where drugs or equipments or gloves, etc. could be available. So my time is up, but thanks so much. Go ahead.
So in terms of what a health system needs to become more resilient, you want to talk about, I think, resilience at the national level, resilience in communities, and resilience in families. Certainly at the national level, they need some form of national emergency operations and standard operating procedures for incidents and outbreaks. For infectious disease outbreaks, they need port of entry screening capability, a national lab system and national surveillance systems that span animal and public health, as well as rapid response teams in case of a reported outbreak. And what we found under the GHSA is that countries are much more proactive than they used to be. They're not hiding reports of new outbreaks. They have rapid response teams. They're sending them out to the field. They're often multi-sectoral. They're able to identify, to diagnose the pathogen in country, or else they know they're able to ship it out of country, and they are beginning to develop some risk communication capabilities. In terms of at-risk communities, which are often border communities or others, they need to be prepared and have their own preparedness plans. Simulations are very useful to have for outbreak response. They also need to be linked. At-risk communities need to be linked into diagnostic networks, as well as surveillance systems. And the one thing that communities need to be able to do is have an active community-based surveillance system to pick up early evidence of outbreaks. In terms of families being resilient, they need simple things like to get their family, their children vaccinated, but also to have trust in health facilities, so we don't get what we're getting regularly on a daily basis in Eastern Congo, new cases of Ebola where people refuse to be followed, even though there were contacts of cases, and they refuse opportunities for vaccination because there was no trust in the health system going forward. So those are a few ideas that I have on this subject.
So I'll say three things, but I want to actually talk mostly about the second and third. First of all, strong data systems, but others have mentioned that, so I won't talk about that. Second of all, is money has to get to the front lines. So WHO recently has issued some data about how much countries spend on primary health care versus secondary and tertiary care. Most of the 30 countries, lower middle income countries, where we have data. Most of those countries spend 1/3 or less of their money on primary health care. In other words, they spend 2/3 or more of their money on secondary and tertiary care. So if money's not getting to the front lines, then you can't have managerial autonomy, you can't have adaptability, you can't have rapid response because money is tied up with urban elites in hospitals. And so money getting to the front lines is something we can do today to help prepare countries for tomorrow. The last area, I think, building on the top bullet point in Kelly's slide on what do countries need, she said state capacity, and what does that mean, though, state capacity? So the World Bank issued an article just a month ago in February that is titled "What is State Capacity?" and the headline of state capacity is, and I'm quoting from the article, "Culture is the crux of state capacity." That if there are expectations and behaviors and norms which are about underperformance and which just underline or highlight or reinforce underperformance, then health systems will underperform. And it's a business axiom that it takes a few months to destroy culture and years and years and years to improve organizational culture. And so this article, I think, is quite powerful because I think it takes us into a new ground, both in terms of our investments as development partners and as technical agencies. What do we build when we build state capacity? It's not technical capacity, it's organizational culture. And what do we measure when we measure resilience or health systems? Well, we should be measuring culture. In Uganda, the article talks about measuring organizational culture using tests from the world of psychology, where they measure integrity, transparency, intrinsic motivation. And if we bring those measures into the health systems world, the resilience world, then I think we're building organizations, health systems, which are adaptable, nimble, which value performance rather than are stuck in cycles of underperformance forever.
Thank you. Those are all incredibly helpful perspectives. And actually, that last response leads me very nicely into my next question. We talked a lot about the critical elements of responding to a health crisis. I want to zero in a little bit on this concept of adaptive capacity. What, in your opinion, are some of the best ways and the challenges in terms of building adaptive capacity of a health system, with the idea that we want to keep improving on how we're responding to crises and not just responding in the same way each time? And maybe I'll start with you because I think you've already spoken to this a bit, Dana, and then move on to the other panelists.
Sure. So I think it's easy to say build organizational culture or build management capacity, but a huge challenge. We've been thinking about how to do this at the Gates Foundation for several years now, and except at a district level, retail level, one-off level, it's a challenge to do this at scale and things like that. So that is a huge challenge. We also see a challenge and an opportunity around the private sector with different data systems, with different incentives, and yet the private sector, as we know, in DRC and Afghanistan and other places, faith-based organizations, NGOs, are huge providers of care. So that's a challenge, the private sector, but we think is an opportunity. I think flipping that private sector to an opportunity, another area to build state capacity, we believe is around contracting, purchasing, and strategic purchasing. Countries which have less mature health systems, which are fragile, are actually opportunities because they have not set down a path of build or buy. They still can make that decision about building or buying health services as has happened in Afghanistan, as happened in the DRC with faith-based organizations, as happened in 1947 when the NHS was founded and was founded on a buy, not build approach to primary health care in a post-crisis environment. So building capacities of governments to contract and purchase, we are seeing at the Gates Foundation more and more that countries want to do this, but how to both cut a contract, but more importantly, how to monitor, evaluate it, replace it, is I think, a real challenge and a real opportunity. The last area that I'll mention in terms of an opportunity or approach that we're starting to increasingly invest in, and my colleague Susna Day is here is leading this, is over the last 3 or 4 years we've been working, or a couple of years we've been working with Kaduna and Niger states in Nigeria around health systems design. And the normative guidance around health systems design today is around access. which means more health workers, more infrastructure. Doesn't take account of fiscal realities and fiscal space, doesn't take account of productivity. Well, productivity is measured through quality and quantity, or health production. And so we're investing in and looking for partnerships around state-of-the-art health systems design so that fragile or less mature health systems can build health systems of the future, which don't just focus on more, but focus on issues around health production, around technology-enabled healthcare, around leapfrogging into systems designs of the future.
Great, thanks very much. A similar question to you, Richard. Can you identify some ways and challenges in building adaptive capacity of the health system? And more specifically, are there specific tools or approaches that you've seen that can help build this capacity?
I think a key thing that's occurred to me on several recent outbreaks, not only the Ebola outbreak in Eastern Congo, but also the Madagascar pneumonic plague outbreak, is the importance on the community level in terms of having credible, effective health facilities where, number one, that are safe, where there's infection prevention control, and water, hygiene, and sanitation. And this is critically important because so many of the outbreaks that we're seeing are transmitted in health facilities, whether it is Ebola, whether it is plague, whether it is cholera or measles. And in addition to having a safe health facility, we want low fees. We want some minimal level of essential drugs to make these facilities something that people trust and will be able to, willing to go to in case of an outbreak, so that they don't go to a traditional provider first and end up 2 weeks later after having transmitted the disease into a health facility. The private sector plays an important role because unless the private providers, who are often the first stop, understand about the disease transmission pattern during an outbreak or willing to refer patients, then you're going to get a lot more transmission as well. And health workers themselves have to be informed and protected, or else you're going to get what you got in West Africa and you're getting in Eastern Congo, is that evidence of other diseases that are normally controlled being out of control during an outbreak because health facilities are abandoned or no longer functional. One other thing I want to mention is, again, the importance of community engagement, because of people who refuse to be vaccinated or refuse to use the health facilities available. And this has to be done on a regular basis. You can't begin the community engagement process the day after a declared plague outbreak or Ebola outbreak, because people are wondering, well, where were you the rest of the year when we had a series of problems that were not addressed. So I think those two things I would focus on is effective, safe health facilities that can engender trust, and making sure that the community feels like the government and the local authorities have been responsive to them.
Thank you. Karima, any thoughts to share on the subject of adaptive capacity and ways forward and challenges? Thanks.
Yeah, thank you. I mean, both the points here were very, very valid and very critical, and I just want to re-emphasize them. One is the community trust, because that is something that is completely broken, particularly in a conflict situation. And until that trust can be built, it'll be very challenging to get them to support you as well, even when you go there. So the way to build that trust is to actually give them as effective service delivery. If you're not able to respond to their needs, you're not going to build that trust. So that's very, very critical. And in the conflict area, public sector cannot go there too much. So working with the private sector, with non-government agency becomes very, very critical as well. And what Dana was talking about, accountability mechanisms like contracting, etc., are critical. And one of the things that we saw in Afghanistan is that at the national level, the same essential package was agreed on. And then the same package was delivered throughout the country with the partnership of public and private sector. So everybody felt that they got the services. Who provided and how it was provided was a different matter. But that became very critical, that the service came to them. And so I think that's very critical. We have to be more innovative in terms of new models of care. Certain disaster areas will not allow you to have a facility, like if you have a climate disasters like flooding, etc. So the outreach services, again, I want to reiterate what David said about mobile clinics, about outreach services and immunizations. These things completely break down, and new diseases come. In Libya, for example, malaria had been eradicated, and we started seeing malaria coming up because of the hygiene situation, because of population coming from different areas. And finally, the citizen engagement side. It's very critical that we not think about developing citizen only after the disaster hits us, but also start building that citizen engagement early on. And the citizen engagement is critical, because they are the voice of the people, and they are the ones who then can link and build the trust in the system. So these are some things I just want to re-emphasize. And I think financing side, we have to look beyond the public sector and also protect the people, the financial protection side. So building the partnership between companies, organizations, getting some subsidies, bringing a larger group of people into the national objective and agenda, not just thinking the public sector is only for public, and private sector thinks differently. Bringing everybody on board is very, very critical, and a very timely effort is required on that. Thanks.
That's great. Thanks very much. Before we close this round of questions, I just want to ask one more time about the tools and approaches and see if there's anything you'd like to highlight in that regard. I know there's a plethora of tools that we use with regard to emergency response, with regard to the Joint External Examination tool, and there's IHR, and there's health, an array of health systems assessment tools. Is there anything you would like to highlight with regard to how these tools that exist build adaptive capacity, or are we missing something in this regard? Do we have, do we have learning agendas built into these tools to help us better our response each time?
So, regular surveys and all that we rely on a lot may not happen because of conflict areas or in disaster areas where you cannot go. We have started relying on GIS, satellite imaging, which picks up, disaster constructions that have been, facilities that have had effects on their construction, populations that are moving around from satellite images. So we are starting to rely on such data through remote access, and where possible, consultative groups try to get data from that, because often it's very difficult to have surveys. But then we do need to have some sort of a survey to have some sort of baseline of where things are and how we can improve. So periodic service, we have this service delivery indicator, which is very much focused on the facility performance situation, and very quick survey. So some of those kind of way to get more information, because we need information. Information is critical. We won't know where things are if we don't get that. So thanks.
Yeah, in terms of tools, I think that simple communication tools like helplines can be useful, but also individual, community by community work to understand what the rumors and the thinking are by communities. We found in Eastern Congo this varied by communities in terms of how they thought about the response, how they thought about the government workers, what their biggest concerns were, why certain communities were very resistant to care-seeking behavior for unexplained fever, or others would refuse to be vaccinated, but it varied by community. To constantly monitor this and understand it and feed it back to the providers are very important.
Great, thank you.
Yeah, so I mentioned service design and contracting and purchasing. Just a third area that I would push us to think about is something I mentioned around technology-enabled health systems and health systems of the future, even for fragile environments. We have to think 5 or 10 years ahead, not just the challenges and the opportunities and the assets and the infrastructure of today. And I do think that what we see in middle-income or low-middle-income countries is going to be relevant for fragile environments. And this allows real-time surveillance. It allows longitudinal tracking of patients. We're seeing this happen in places like Rwanda, and we know that it's relevant for fragile environments. So I remember visiting Athena Health in Boston about 3 years ago, who processes about 10% of all the claims in the U.S. for smaller providers, not for the big providers. They know about a flu outbreak in parts of the U.S. 6 weeks before the CDC does, and tells the CDC what's going on, just by looking at claims data. And so while one may think, well, that's Atlanta, that's Boston, I think that's relevant for DRC and Liberia and Sierra Leone.
Great, thanks very much. So we're going to do one more round of questions to all panelists, and then we'll open it up to the audience. But we're going to combine two kind of different questions, so it's up to you as to how you'd like to answer this. But the first question is, what lessons can we learn from other sectors? Climate change comes to mind, for example, in terms of building the kinds of systems that promote adaptive capacity. And then the second question is, how can donors and global partners best support the ability of countries to respond and adapt to crises from the perspectives of where you sit? Perhaps we can start with Richard first this time. Thanks.
Thanks very much. I understand you're going to hear about the Global Resilience Initiative, which brings in a multi-sectoral profile to make populations in the Sahel and the Horn of Africa much more resilient to shocks that occur regularly. Some of the important lessons include having diversified livelihoods for families, so they don't have to so that they don't get a health shock and they immediately have to sell off all of their valuable belongings. And it could be micro-enterprise, it could be diversified in terms of agriculture, better, more resilient seeds to drought. It could be livestock or ruminants, sheep and goats, particularly focused on women. These things make families, particularly women, more resilient. In addition, there's also a governance issue. I went to DR Congo in 2001 to work on a health and humanitarian action plan, and the issue was in Eastern Congo like it is now, and we were talking about all the things we were going to try to do to integrate humanitarian with development programs, etc. And then the political officer at the embassy basically said, what you need to do is stop the war. And that's the most important thing you can do to promote the improved health outcomes in Eastern Congo, and that's probably true now as well. So there's an element of conflict resolution, peace building, governance, which is absolutely critical. When you have a situation in Eastern Congo where nothing in their own minds was done to benefit the population, and then all of a sudden 600 WHO workers, foreigners, and foreigners can be anybody outside of North Kivu, Ituri areas, descend on with a whole bunch of resources. That doesn't bode well with people. So this is an ongoing issue, not only conflict resolution, peace building, and governance, because you just can't turn it on at the time of a outbreak.
Thank you. Dana, would you like to go next?
Sure. A couple things. One is There's another sort of axiom from the business world that says that today's performance is actually a misleading indicator of business health, that the things you do today come out the other side 3 or 4 years from now in terms of business performance. And so I would say to development partners, what are we doing today that addresses tomorrow's problems and the organizational health or performance of less mature, fragile health systems? And the USAID Resilience Framework from 2012 suggested that more and more development finance and donor funding is going into fewer and fewer countries. And what are we doing today to help those countries absorb that money, to help absorb the money that comes with crises and post-conflict? And I would argue probably not enough. We're not, and understandably because we're addressing today's problems and today's needs, but I think you have to have a balance of today and tomorrow when you're talking about health systems resilience and the future. As I said earlier, fragility and health systems immaturity is an opportunity, and I don't see us seizing that opportunity enough. I see development partners moving into post-conflict environments and money moving into post-conflict environments, for example, and not a really hard conversation around build versus buy, for example. I see mostly people with government background and public centric health systems backgrounds going into those countries, and the private sector person is over in the corner sort of writing their chapter, and you end up, of course, with a build approach. I'm not saying build versus buy is the right thing, build or buy is the right thing everywhere, but are we really giving that a fair shake as we're thinking about helping countries to establish health systems that are fit for purpose and fit for the future? I do think the fragility is an opportunity for leapfrogging, for other sorts of things before vested interests set in. So.
Great, thank you. Karima, any thoughts to share on this?
Yeah, so I just wanted to mention about the 3 initiatives that we have at the bank. 2 of them are non-health and one is a health sector initiative. And 2 of the non-health initiatives are in the Africa region particularly. One is called the Catastrophic Deferred Drawdown Option, which is to support the capacity of countries to manage the risk of natural disasters. We have this development policy lending program, and which has a contingent credit line that we provide, and that provides immediate liquidity to countries in the aftermath of a disaster. In order to qualify for that, the country must have a disaster risk management program already in place. The funds can become available for disbursement after the declaration of a state of emergency due to natural disasters. So we've recently developed this fund and this option where the country can really get immediate liquidity, which is a big crisis that they face following a disaster. The other is scaling up social protection programs. Again, it's an Africa initiative, which leverages on the structures and system of existing social protection programs that we have in the country, and can provide rapidly support to exposed and vulnerable population after a shock or disaster. This includes not only the poor, because most our social protection programs will be focusing on that, but also some others who are vulnerable to falling into poverty and when exposed to a shock. The objective is to mitigate the direct impact on household asset and welfare losses in the direct aftermath of a disaster, but also to prevent some immediate term impacts, including forced displacements and negative coping mechanisms such as selling of productive assets. The scalable social protection programs have already been proven their efficiency in many countries, including Kenya and Ethiopia. And finally, I just wanted to mention our program, which is the pandemic emergency financing facility that we have. The World Bank Group, with the support of Japan, Germany, and WHO, has developed the Pandemic Emergency Financing Facility, which is a quick dispersing financing mechanism that provides a surge of funds to enable a rapid and effective response to a large-scale disease outbreak. Eligible countries can receive timely, predictable, and coordinated surge financing if affected by an outbreak that meets the Pandemic Emergency Financing Facility criteria. The PEF breaks new ground by providing the first-year insurance for pandemic risk, offering coverage to all low-income countries eligible for funding under our concessional loans. And I just wanted to mention now that we've recently also launched a specialized bond aimed at providing financial support to the PEF, our financing facility. And this marks the first time the World Bank bonds are being used to finance efforts against infectious diseases, and the first time that pandemic risk in low-income countries is being transferred to the financial markets. Thanks.
Great, thanks very much. Well, first of all, thanks to all of you for the very rich responses and ideas and explanation, not only on some of the major initiatives in terms of what's happening in terms of supporting response, but also where we should be going in this area. If I'm calculating correctly, I think we have 10 minutes for questions and answers and then 5 minutes for wrap-up. Is that right? Okay, so with that, let's open up the floor to our audience. As with last time, I would please ask you to identify yourself before asking the question, and then I'd say maybe ask the full panel, and we'll have a volunteer from the panel to answer first, and then we can have add-ons. Thank you. Please over here, and then over here, and over there.
Hi, everyone. Thank you very much for this panel. Great insights. My name is Ash. I'm from Harvard University, and I work on access to medicines. I have a lot of questions, but I will focus on my area of work. We have seen a lot of time that a lot of countries do have a basic healthcare infrastructure. They might have resources, they might have human resources, they might have hospitals and investment, but have not been tested in times of crisis or epidemics. And quite a few times, donor countries or even donation from pharmaceutical companies are kind of misaligned. So my question is, from your experience, what can be done to have a better coordination among donors to make the access to medicines and drugs in times of crisis more efficient? Are there cases that you've seen that worked well and that have been tested? And what are the roles and responsibilities of the member states as well? Thank you.
Sure. Maybe let's take a couple questions, maybe 3 questions, and then we'll have our panel answer.
Igor Linkov, Army Corps. In many fields that I am working in, the big question always is how you do trade-offs between efficiency and resiliency. Naturally, in many systems, we invest to make them more efficient, especially in countries in Africa. Resilience requires additional investment. It requires investment for something that you may not even see unless you have a crisis. You may not be able to test it. So how in World Bank or Gates Foundation you deal with these issues? How to make a business case for resilience?
Thank you. Maybe one more, and then we'll take some answers and then start again.
Hi, my name is Kelly Bridges. I work with an organization called Global Water 2020. I really appreciated the remarks by Richard and earlier by Dr. Sohail and Kelly Saldana on the issue of WASH in healthcare facilities. So we know that WASH is a big problem in a lot of healthcare facilities. Half of healthcare facilities worldwide lack access to safe, to piped water. Another 35% lack access to soap. And we know that this played a big role in the Ebola outbreak, where we found 103 times higher incidence of Ebola in healthcare workers than in the general population. But despite the critical need for WASH in healthcare facilities, we find that it's been overlooked in policies, it's been overlooked in institutional strategies, health finance, and Ministry of Health budgets, including the Global Health Security Agenda, of which only a few countries, largely those in West African nations, address the issue of WASH in their country roadmaps. So with all that being said, my question is, how should we go about, as the global health community, in addressing the critical needs in the physical environment where quality of care is to be delivered?
Thanks very much. I think we'll pause here, though I saw some other hands up. So let me just hold, Anwar, let's hold for this second, and let's give the panelists an opportunity to respond to these 3 questions. One was around coordination of donors related to access of medicines and how we can improve that. Another one regarding comments around trade-offs between efficiency and resiliency and how that balance is being discussed and taken into account. And then the 3rd question was related to WASH in healthcare, which is often overlooked in policy and budget strategy. How can we respond to that? So Karima, let's start with you first, and maybe we'll give each panelist a quick opportunity to respond.
Yeah. Thank you. So on the aspect of the coordination of access to medicine, When the World Bank goes to a country to provide support, the first thing it looks at the country systems that are in place, including the essential packages for drugs and services. And if further discussion is required on that aspect, that's where we go. Of course, we work closely with WHO and other agencies who are experts in this area. And the financing that we provide then supports that essential health package, so essential services as well as the essential drugs that are, the critical drugs that are required. So, and then also to move the country to think about, where those drugs could be procured from, and how do we make sure that we get the affordable prices for those drugs. So bulk procurement and such mechanisms are explored in the system. Of course, what happens is we do see a lot of challenges happening in the private sector. Private sector starts responding when there's a shortage of drugs. A lot of fake drugs come into the market, and again, this challenge, if you don't have a proper system in place in terms of standards, in terms of accountability, in terms of monitoring, then that happens. It leads to a challenge. We recently saw in Libya a lot of insulin drugs being brought into the market at very high prices by the private sector when there was a shortage for diabetes care in the hospitals. But not that the necessary drugs were available, but some of the unnecessary drugs were in surplus. So these are things to dialogue with the private pharmacies, the private sector, to bring them together, to buy into the essential package and the needs for that, so that those drugs are also advocated and brought into place. So I guess we can go around and then come back to the second question. Yeah,
Or I'd say comment on all three. You don't have to answer all of them, but whichever one speaks to you and you'd like to comment on. Yeah, go ahead, Richard.
Yes, on the question about WASH, I would expand that to not only WASH capability, but infection prevention control, which is waste management, availability of things such as personal protective equipment, isolation when needed. So it's really an issue of both infection prevention control and WASH. And yeah, there hasn't been as much investment, but these are costly, they're relatively costly items. If you don't have a water source or to make a regular supply, to make sure you have waste management capability, isolation, etc., it's something that does need more attention, because if you have donors that invest at the level of the primary hospital or a health facility, then they can't turn a blind eye to the safety and the sanitary conditions of that hospital, even though they may be supporting one critical aspect, whether it's essential drugs, immunization programs, maternal and child health, etc. That's something we're struggling with at USAID as well. In terms of the business case for resilience, yeah, spending a lot of money to prevent something, but the donors may end up spending close to $500 million, one could project, to control this Ebola outbreak in Eastern Congo. You'd think that a relatively modest investment in surveillance, laboratory systems, emergency operations, risk communication would be something that would be seen as cost effective. One last item in terms of coordination for essential medicines and drugs and diagnostics. I think more work needs to be done on the case management of some of these epidemic-prone diseases, because as we saw from the Lassa fever outbreak in Central Africa and the pneumonic plague, there needs to be some work done on case management, SOPs, and critical drugs for these sometimes rare but often deadly outbreaks when they occur.
So very quickly on the access to medicine. So are investing, but I think USAID is a major mover in establishing global visibility and analytic networks for supply chain. Imagine air traffic control, where you can see what's coming from manufacturers, from major procurers like USAID or UNFPA for contraceptives, from NGOs. So we actually can see in real time what's happening in terms of access to medicines and movements into country. And this is being piloted in a couple of countries for family planning under FP 2020 and for vaccines. And we think that's a huge part of the future. That doesn't solve the 7 different supply chains that there are in Nigeria. There are 12, I think, or so separate vertical supply chains in Malawi. That is, I think, the bigger prize and the harder prize, but at least we can start by working better together at a global level to see what arrives at port. In terms of just building on Richard's comment around efficiency, I know Bill has been frustrated by the lack of measures around health system strength. The DFID parliamentary inquiry 3 years ago or 4 years ago around health systems concluded 2 things. One is they didn't know how much they spent on health system strengthening as a UK government, and second of all, they didn't know what they got for it. And so having better measures of health system strength and resilience, the Primary Healthcare Performance Initiative is working on that. It's just launched a scorecard. Margaret's work and others' work on a resiliency index, we think is important to make the case that if you invest in something, something else comes out the other side in terms of strength, because otherwise you just have no sense of an ROI.
Great, thank you very much. I think we have time for 2 to 3 more questions, and I saw a hand up there. Yep, from the beginning.
Hi, Lisa Nichols from Aft Associates. I wanted to ask, what are the lessons from our response, governments, and the global public health to HIV/AIDS? I haven't heard it mentioned. It was a very sweeping pandemic. The models were all wrong. There's a huge social safety net, but we still have a long ways to go. We only recently saw that in Cote d'Ivoire, the private sector is now allowed to treat HIV patients. They were not up to a few years ago. So what are we doing to learn from that, but also not to continue to address things in a parallel, siloed way? So, thanks.
Is there any, Bev, go ahead. There's one question here.
Hi, thank you all. I'm Beverly Johnston with USAID's Office of Population and Reproductive Health. And I took your comment very well, Richard, about the need for trust in the health system, right, and how important that is to engage the community, particularly right after a crisis or an epidemic and the like. But when you think about health systems more broadly and kind of the everyday health systems, can you talk a little bit more about what community engagement would look like and what we should know from the USAID side, what we should be doing on USAID side about community engagement towards trust in our standard projectized world that we live in? Thanks. And thank you, Karima, too. I know you mentioned it.
Okay, I think these will be the last 2 questions, and then we'll just have some closing remarks. So the questions were related to what we've learned from the response to HIV, and then any examples of models related to community engagement, tying back to some of the comments that have already been made from panelists. Perhaps let's start with Richard, and then Karima, and then Dana on this one.
I'll say just a few words about community engagement. Some of the basic things which I think continue to work is basically the community co-management of health facilities. This is an old concept in terms of primary health care going back decades, but it works to have a community management committee that understands everything from the pricing of services to be participating in cleaning up the area. I think that's very important. Dialogue when there is something new that happens with the community, things such as helplines and having healthcare workers and extension workers from the community themselves is very important. So these are, and also having community simulations. When I was in Bangladesh, there were community simulations for possible typhoons, which were big events, and got everybody to understand at least part of what they needed to do. And we certainly can have simulations regarding infectious disease outbreaks as well. So these are some simple things that can build community engagement, which has to occur not just in times of outbreaks, but throughout the year.
So I already see the signs, so please wrap up. So just quickly 2 points that I wanted to mention on the HIV question. And one was that really good to see that there's a public-private partnership sort of forming in Cote d'Ivoire. I remember in Philippines on the TB DOTS program, this is the USAID program again, where the public-private partnership was able to really increase the DOTS coverage. And the issue, obviously, that was external financing. The issue was how would you sustain that. So I don't know what the model is in Cote d'Ivoire of bringing the private sector in, who's financing it, how do you sustain it, what are the incentives created for that. And finally, one more thing I want to add is that this HIV epidemic and HIV issue is still a lingering issue, and particularly when we have international resources dwindling, how do we get domestic financing to increase when we have this huge agenda on SDG coming up with universal health coverage, essential package, MCH, etc., non-communicable disease also being added to it, and not enough domestic financing allocated towards these issues. So I think if the government is moving towards improving access to services and bringing more partnership, perhaps there's this proper monitoring, accountability, those kind of things happening, which will be critical to ensure that the sustainability of the program happens, would be really critical to move that agenda. Thanks.
So just because we're at time, or perhaps slightly over at this point, Dana, I'm going to give you the last word, not only in response to these questions, but for the whole panel. So perhaps if you have a very, very quick response related to these questions, but if you'd like to make a last closing remark as well to wrap up the panel, that would be great. You have the honor to do that.
That's a lot of pressure. So, Lisa, that's a great question. I don't know if we are, as a community, learning. I know that our HIV/AIDS team and the foundation is trying to shine a light again on prevention and primary prevention. I've spent my 1990s working on primary prevention with PSI, and it feels like the HIV world lost its way, and so maybe and is trying to shine a light again on primary prevention. So that could be one lesson, because prevention is better than cure. And Nazo knows that my song all too well about when we talk about community health, we often then immediately pivot to community health workers, and I think community health is much more expansive than that, and includes people as agents of their own health care. And so I think starting with that and then moving up to community health workers or to schools or whatever is the prize. We love community health workers, don't get me wrong, but that is sometimes a solution looking for a problem. My last maybe comment then, just to be a bit provocative, you can't come to a USAID meeting without mentioning universal health care and universal health coverage. And so I think the UHC movement is actually a huge opportunity, but also a threat to this community around health systems resilience. UHC is defined right now as more coverage, more people covered, more health benefits covered. It doesn't measure system strength and resilience, as Igor rightly points out. It doesn't measure health production and productivity, and most importantly, it leaves quality off the agenda. And so I think as we think about building health systems of the future and moving from fragility to mature health systems, that making sure that universal health coverage is and universal health care is defined such that it builds these systems of the future and isn't just about more, but is about better, is, I think, the real challenge and the real opportunity in front of us.
Thank you very much to all three of you. I just want to give you a very heartfelt thanks for being here today and for lending your very rich perspectives. Thank you very much, Dana, Richard, and Kareem. If you all would join me in thanking them, and I think we're ready for our next panel.